Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute monocytic leukemia. This is an acute myeloid leukemia with monocytic differentiation that lacks defining genetic abnormalities. Extramedullary disease is common in this entity, particularly involving the gingiva, the skin, and the central nervous system. The pathogenesis is unknown, and morphologically, it is characterized by a hypercellular marrow with infiltration of immature cells. Monoblasts have round to oval nuclei with one or more prominent nucleoli in the bone marrow aspirate smears. Promonocytes show delicately folded convoluted nuclei and inconspicuous nucleoli. However, differentiating promonocytes from monoblasts is not important when it comes to enumeration because promonocytes are considered blast equivalents. Delicate lace-like chromatin is seen in both monoblasts as well as promonocytes, and basophilic vacuolated cytoplasm and azurophilic blue granules can be seen in both. By immunophenotype, these blasts express myeloid-associated antigens like CD13, CD33, which is usually bright, CD15, CD65, and CD117, and they may express CD34, and they usually express HLA-DR, but these can be negative. Markers of monocytic differentiation may be expressed by pro-monocytes and more mature monocytes, like CD4, which can be dim, CD11b, CD11c, CD14, CD36, which tends to be bright, and CD64, which tends to be bright as well, and CD163. Co-expression of two or more monocytic markers is characteristic of monocytic differentiation. The essential criteria to make a diagnosis include identifying at least 20% blasts or blast equivalents, like promonocytes, in the bone marrow or the peripheral blood. At least 80% of the leukemic cells are monocytes and their precursors, including monoblasts and promonocytes. You need less than 20% maturing granulocytic cells, and this leukemia should not be fulfilling criteria for acute myeloid leukemia types with defining genetic abnormalities or myeloid neoplasm post-cytotoxic therapy. The differential diagnosis for this entity includes microgranular acute promyelocytic leukemia, AML with NPM1 mutation, AML with KMT2A rearrangements, and CMML, which is chronic myelomonocytic leukemia, which can sometimes be really challenging to differentiate CMML from acute monocytic leukemia. When it goes into the tissue, it can cause monoblastic sarcoma, and this may be confused with malignant lymphoma or soft tissue sarcomas and can be distinguished with CD45, CD43, CD68, and CD163 staining on immunohistochemistry. This is the end of this video. I'll see you next time.